We're entering domain 2 now, and this is the heaviest part of the exam, sector by sector. And we start with healthcare because it has the deepest, oldest, and most detailed privacy regime in America. 5 focus areas. First, HIPAA's architecture. Who's covered, who isn't, what counts as protected health information, and the business associate chain. Scope is everything here because HIPAA's reach is narrower than people assume. Second, the two main rules, the privacy rule governing uses and disclosures, the security rule governing safeguards and its proposed modernization. Third, the modern problem, online tracking technologies on healthcare websites. This is where a 1996 statute meets 2026 ad tech, and it's messy. Fourth, HITECH, enhanced penalties, breach notification, audits, plus the Cures Act and the special rules for substance use disorder records under 42 CFR Part 2. And fifth, insurance, the NAIC model laws and how state variation works in a sector with no federal regulator. Let me start by correcting the single most common misconception in American privacy. HIPAA does not protect health information. HIPAA protects health information held by specific entities. That distinction is everything. So who's covered? 3 categories. Health plans, which includes insurers, HMOs, employer group health plans above a threshold, and government programs like Medicare. Healthcare clearinghouses, which are the intermediaries that translate data between formats. And healthcare providers who transmit health information electronically in connection with a covered transaction. Read that last one carefully. Not all providers. Providers who conduct standard electronic transactions, billing insurance essentially. So a cash-only therapist who never bills insurance electronically, possibly not covered. And now the gaps. Your fitness tracker isn't a covered entity. Your period tracking app isn't. Your genetic testing service generally isn't. Your employer holding your sick note isn't in that capacity. A social media platform where you discuss your diagnosis certainly isn't. I've had this conversation with clients so many times. They say, we handle health data, so we're HIPAA regulated. And I ask, do you bill insurance? Are you a plan? Are you a clearinghouse? No. Then HIPAA doesn't touch you. Which sounds like good news until you realize what it means for consumers. The most sensitive data about you might have no federal protection at all. That gap is exactly why Washington passed My Health, My Data. Remember that. We'll come back to it. So covered entities don't work alone. They have vendors, and that's where the chain extends. A business associate is a person or entity that performs functions involving protected health information on behalf of a covered entity. Claims processing, billing, data analysis, cloud hosting, legal services where PHI is involved, transcription. And here's what HITECH changed. Business associates are now directly liable under HIPAA. Before 2009, they were only bound by contract. Now, HHS can enforce against them directly. That's a big deal. Then there are subcontractors. If your business associate hires someone who touches PHI, that subcontractor is a business associate too. The obligations flow all the way down. Contracts at every link. Now, what's PHI? Individually identifiable health information relating to past, present, or future physical or mental health, the provision of care or payment for care, transmitted or maintained in any form. And the identifiers matter. There are 18 of them in the safe harbor de-identification method. Names, geographic subdivisions smaller than a state, dates more specific than year, phone numbers, email, social security numbers, medical record numbers, device identifiers, biometric identifiers, full face photos, and any other unique identifier. Here's the practical wrinkle, the conduit exception. A postal service or an ISP that merely transmits data isn't a business associate. But cloud providers who store PHI, they are. Storage is not transmission. That distinction has decided real cases. Now let's get to what the privacy rule actually demands. And I'll give you the mental model first. The default is prohibition. You may not use or disclose PHI unless the rule permits or requires it. That's the opposite of most American privacy law, where you can do things until told to stop. So what's permitted? Treatment, payment, and healthcare operations, the famous TPO. A doctor can share your records with a specialist for treatment. A hospital can send your data to the insurer for payment. Quality improvement activities count as operations. None of that needs your authorization. Disclosures to the individual themselves are required. So is disclosure to HHS during an investigation. Beyond TPO, you generally need a written authorization, and it has specific required elements. Description of the information, who's disclosing, who's receiving, purpose, expiration, right to revoke. Then there's minimum necessary. When you use or disclose PHI, limit it to the minimum needed for the purpose. Notice, this doesn't apply to treatment disclosures because you don't want a doctor working from a redacted chart. Individual rights, access to your records, amendment, accounting of disclosures, request restrictions, confidential communications, and the notice of privacy practices. That form you sign at every doctor's office and never read? That's this. Let me ask you, have you ever actually read one? The privacy rule tells you what you may do. The security rule tells you how to protect it. And it applies only to electronic PHI. 3 categories of safeguards: administrative, physical, technical. Administrative is the biggest. Risk analysis, risk management, workforce training, access management, contingency planning, evaluation. And risk analysis is the foundation. Almost every HHS enforcement action I've read includes a finding that the organization never conducted a proper risk analysis. Physical safeguards: facility access controls, workstation security, device and media controls. Where's the server? Who can walk into that room? Technical safeguards: access control, audit controls, integrity, transmission security. Now, here's what makes the security rule unusual. It's technology neutral and scalable. And specifications come in 2 flavors. Required, you must do it. Addressable, you must assess it and either implement it or document why it's not reasonable and implement an equivalent. Encryption is addressable. Yes, really, it's not mandatory, it's addressable. That surprises people, but it made sense in 2003 for a small practice. Now the modernization. HHS has proposed a significant update and the direction is clear. Make more things required. Mandate encryption. Mandate multi-factor authentication. Mandate asset inventories and network mapping. Addressable was a product of its era. That era is ending. This one is genuinely fascinating because it's a collision between 2 worlds. Here's the scenario. A hospital has a website. Marketing wants analytics, so they add tracking pixels. Standard practice. Every organization does it. Now a patient visits the hospital's oncology page or uses the appointment scheduler for a psychiatry clinic. The pixel fires. It sends the URL, the IP address, and a persistent identifier to a third party. So what just happened? An identifier plus a page about cancer treatment. That combination reveals something about an individual's health condition. Is that PHI? HHS said yes in guidance issued to covered entities. Their position was that IP addresses combined with health-related page visits can constitute PHI, even for unauthenticated users just browsing. And the industry pushed back hard. Litigation followed, and a court vacated parts of that guidance, particularly the unauthenticated user portion. But here's what I want you to understand. The vacature didn't make the risk go away, because state wiretapping statutes, session recording claims, and class actions under laws like CIPPA are still live. And the FTC's health breach notification rule reaches non-covered health apps. I've sat with hospital marketing teams who genuinely had no idea their pixels were a legal problem. They weren't reckless, they just used the same tools everyone uses. So ask yourself, What's on your organization's most sensitive web page right now? HIPAA passed in 1996 with essentially no teeth. HITECH in 2009 gave it teeth. Let's start with why. HITECH was part of the stimulus package and it poured billions into electronic health records adoption. Congress reasoned, if we are digitizing everyone's medical records, we'd better make the privacy rules enforceable. So what changed? First, business associates became directly liable, as we discussed. Second, breach notification became mandatory, which we'll cover next. Third, and most importantly, the penalty structure. HITECH created 4 tiers based on culpability. Tier 1, you didn't know and couldn't reasonably have known. Tier 2, reasonable cause but not willful neglect. Tier 3, willful neglect corrected within 30 days. Tier 4, willful neglect not corrected. And the penalties escalate sharply across tiers with annual caps per violation type. Willful neglect uncorrected is where the numbers get frightening. Notice what that structure does. It rewards correction. If you find a problem and fix it within 30 days, you drop a tier. That's a powerful incentive, deliberately designed. HITECH also gave state AGs authority to enforce HIPAA, and it mandated an audit program which OCR has run in phases. Here's my practical takeaway. The tier system means your response to discovering a problem matters as much as the problem. Willful neglect is a state of mind. Prove you acted and you change your tier. So something went wrong. What does HIPAA require? First, the definition. A breach is an impermissible acquisition, access, use or disclosure of unsecured PHI that compromises security or privacy. And unsecured is a term of art. It means not rendered unusable through encryption or destruction meeting HHS specifications. That's your first lesson. Properly encrypted data that's lost is generally not a breach. Encryption is a safe harbor. This is why encryption, despite being addressable, is functionally essential. Second, there's a presumption. Any impermissible use or disclosure is presumed to be a breach unless you demonstrate low probability of compromise through a risk assessment. And that assessment has 4 factors: nature and extent of the PHI, who used or received it, whether it was actually acquired or viewed, and the extent to which risk has been mitigated. Now the notification obligations. Individuals, without unreasonable delay, no later than 60 days from discovery. HHS, and here's the split. 500 or more individuals within 60 days. Fewer than 500 annually within 60 days of year end. Media notification if 500 or more in a state or jurisdiction. And business associates notify the covered entity, not the individuals. That 500 threshold is the one to memorize. It appears constantly. Let me flag the operational trap. Discovery starts the clock, and discovery means when any workforce member knew or should have known, not when legal found out. Let's cover 2 special regimes because they pull in opposite directions. The Cures Act 2016 is about access. Its privacy-relevant piece is information blocking. Providers, health IT developers, and health information networks may not engage in practices that unreasonably interfere with the access, exchange, or use of electronic health information. There are exceptions, including a privacy exception and a security exception, but the default is share. Why does this exist? Because for decades, health data was hoarded. Patients couldn't get their own records. Systems didn't interoperate, sometimes deliberately. The Cures Act said, stop that. Now flip. 42 CFR Part 2 governs substance use disorder treatment records from federally assisted programs, and it is far stricter than HIPAA. Historically, it required specific written consent for almost every disclosure, including for treatment, no TPO exception. Why? Because Congress understood something. If people fear their addiction treatment records will surface in an employment check or a custody dispute, they won't seek treatment. The privacy protection is a public health tool. Recent rulemaking has aligned Part 2 more closely with HIPAA, permitting a single consent for TPO. But the re-disclosure restrictions remain tighter. So here's the tension. Cures says share more. Part 2 says share less. Both are right for different reasons. Which one wins in a given case? That's the practitioner's job. Now let's shift to insurance. And the first thing to understand is structural. Insurance in America is regulated by the states, not the federal government. That's the McCarran-Ferguson Act. So how do 50 states coordinate? Through the NAIC, the National Association of Insurance Commissioners. It's not a regulator, it's an association that writes model laws which states then adopt, modify, or ignore. Model number 670 is the Insurance Information and Privacy Protection Model Act, an older comprehensive framework covering notice, access, correction, and disclosure limits. Model number 672 is the Privacy of Consumer Financial and Health Information Regulation. This one implements GLBA for insurance, and it goes beyond GLBA by adding health information provisions with opt-in consent. Notice that GLBA uses opt-out for financial data. Number 672 requires opt-in for health data, stricter. Model number 668 is the Standards for Safeguarding Customer Information, essentially the insurance analog of the GLBA Safeguards Rule. Model number 674 is the Insurance Data Security Model Law. This is the modern one. It requires a written information security program, risk assessment, board oversight, third-party service provider oversight, incident response planning, and notification to the commissioner within 72 hours. Here's the practical point. Adoption varies. A national insurer must track which states adopted which model in which version with which amendments. 51 variations on 4 documents. Welcome to insurance compliance. Let's close this chapter by pulling the healthcare and insurance threads together because the state layer changes everything. Start with the principle. HIPAA sets a floor, not a ceiling. It preempts contrary state law, but only where state law is contrary and less stringent. If a state law is more protective of the individual, it survives. So HIPAA is a minimum. And states have built on it enthusiastically. California's CMIA, the Confidentiality of Medical Information Act, reaches entities HIPAA doesn't and provides a private right of action which HIPAA famously lacks. Texas has a broader definition of covered entity that captures almost anyone handling health information. New York's SHIELD Act adds security requirements. Then the special categories. Many states have heightened rules for HIV status, mental health records, genetic information, and reproductive health. That last one has become intensely political, and several states have passed SHIELD laws restricting disclosure of reproductive health data to out-of-state investigations. For insurance, the variation is the whole story. Which NAIC models did the state adopt? Which version? What amendments? Here's what this means for you as a practitioner. There is no such thing as HIPAA compliance alone. There's HIPAA plus every state where you operate. And for the exam, the pattern is what matters. Federal flow, state enhancement, sector overlay. Learn the pattern, not 50 statutes.